Thank you, Frank. Look, it's great to be a part of this series of presentations today, and it really felt that I could really resonate with Charles's introductory keynote, and also really, I guess, hearing from Fazana just then just really what sits at the heart of what we do in our work and why we stretch far and wide in advocating for palliative care and change. What I'd like to say today, though, is looking back on 2020, with the huge impact that COVID-19 had on our health services, who would have thought I could be asking this question about shining our light brightly, and who could be making this claim around the absolute ability to take maximum opportunity? But really it did. The pandemic did provide exceptional opportunity for us to step forward, and for my team to certainly be part of showing excellence in leadership. Next slide, thanks. Frank. Out of all the actions we needed to take in preparing and doing the work that the pandemic demanded of us, I identified three key practices that really helped us to focus our leadership: seeking the opportunities, connecting and together with established and trusted relationships, and then taking those relationships and influencing them, often hopefully enabling others to advocate on our behalf, but also for us to be demonstrating and doing the hard work ourselves. As director of, still at the same slide, Frank. As director, I have an awareness of the developing landscape of palliative care and know about the broad clinical reach and the influence that we're trying to have across our health services beyond just care of the dying and the deteriorating person, even though it's so important and critical. So when we heard about the pandemic, it really solidified my resolve to seek out those new opportunities. And for many of us have been advocating for change further and further upstream. But really, this was the time to act. And if I didn't act now and take those opportunities, with the pandemic settling and passing in anticipation, we could have lost those opportunities to move ahead. What I think is important, though, is we needed to prove our credibility, and what better way to do this than our actions and demonstrating good patient and family care, as well as helping and connecting staff at these times of great stress. It is good to give you a little sense of the context of the work that I do. I'm operating at two levels in my job. Not only do I work at St Vincent's Hospital, Melbourne, which is a large metropolitan tertiary hospital with a relatively well-developed palliative care service across the organisation. In fact, with about 100 staff working in the palliative care domains with 2 palliative care units, a consultation service and cancer and chronic illness clinics. We also support a statewide education, training and research centre. Meanwhile, my other job, which is usually about 1.5 days a week, is really looking at Safer Care Victoria, which is actually the continuous improvement, patient safety and policy influencing arm of our health department. I'm actually the clinical lead for Victoria and was then able to coordinate and work with our palliative care clinical network in the space. What's important, though, is that I think for many of the speakers we've heard this afternoon, it is about reframing what palliative care is all about. And much of that is reframing is earlier interventions, but I really think we have an excellent opportunity to demonstrate skills far beyond just earlier intervention, more broadly focusing on communication skills training, building ethical decision-making into care, and true person-centred care should be at the heart of all healthcare, not just palliative and end-of-life care. The timing of the pandemic did make a difference for us. People may be aware that as an island nation, we were given the opportunity to take advantage of a few months before the pandemic really started to take hold in Australia. We were much less overwhelmed than many other countries that are presenting today and around the globe. And in fact, we most probably had one of the lowest death rates from COVID-19 across the pandemic. So we could plan not only to pivot and to reassess and realign our services, but also plan for hopefully an expected future beyond COVID at the same time. Next slide, thanks, Frank. Focusing back on seeking, I really felt this was an opportunity for our health services in planning for the pandemic. It was edifying for relationships already established that we were able to be invited on to, after a lot of lobbying, by our infectious diseases colleague, our respiratory colleagues and our ICU colleagues to be on the key organisational pandemic committees. I was only too willing to link up with these committees and demonstrate how we could be part of the patient triage system from ED to ICU and develop key points where we could actually add value to every part of that triage process with palliative care. We were also involved in the daily management virtual ward rounds, which were key and run 3 times a day across the hospital. We were also very pivotal in organising the opening up of visitor restrictions so that people who were moving towards dying as a likely outcome were able to actually have visitors come into the hospital to see them rather than just rely on telehealth and other visual aids of communication. It was also extremely important that we were able to help our frontline staff develop mentoring skills and abilities in communication at the coalface. We also had a suite of palliative care tools that, from advanced care planning to the care of the dying, that our academic colleagues were able to take hold of and refocus the documents to be COVID specific and to allow us to streamline our prescribing to be appropriate to COVID-19 and end-of-life discussions, medications and delivery of care, even though we weren't the ones no longer delivering that care at the coalface. What I think is important now is that we now have quite a presence in 2 very important meetings that bookend the entire patient journey in the hospital. What's exciting is that we go to a daily medical intake meeting where every new medical patient in the hospital is discussed. They're not necessarily looking for palliative care, we're just there to give our opinion from a palliative care lens. At the other end, not only we are obviously connecting to about 75% of our patients that are dying within our hospital, but we're also connecting with the people that have become stranded in the healthcare system and can no longer move in the system and need more senior and more broader looking at how we can help those stranded patients who may have been in our hospitals for 3 to 6 months to move through the system to find a place elsewhere beyond the hospital walls. So I think it's really important that we've been able to bring that holistic palliative care attitude and lens to these complex systems. At the department level, at Safer Care Victoria, similarly we pivoted our palliative care clinical work to become part of the clinical health advisory meetings that were directly influencing the Health Minister and our Chief Medical Officer's Pandemic Task Force Committee, really finally cutting through the red tape of government. It's so exciting when you can say that. But I'm sure that many of you can relate to that, those difficulties of working within departments of health and so forth. It was really satisfying to bring about evidence into practice more quickly and to be agile but proportionate in change at many levels of the clinical coalface. I felt most rewarded when palliative care in this situation was asked to review significant visitation exemptions for palliative care, end-of-life care, paediatrics and maternity across the state. Again, our work at St Vincent's had really demonstrated that you could work with COVID and allow people to access visitation at the most critical parts of their end-of-life care journey. Now it's pleasing to say that we have significant palliative care representation in our health department that's secured and it's ongoing, which is fantastic. At one stage it looked like during COVID that we were going to lose our positioning and representation through amalgamations, but really what's it allowed for is ongoing engagement as we move back into business as usual. Thanks, Frank. What I think is important is that we have been very much involved in influencing and trying to keep people involved in palliative care. In connecting prior to the pandemic, our palliative care services are already very well known. We had key members of the hospital executive who really knew our work, such as our Chief Medical Officer, our Chief Nursing Officer, Mission Directorate, and many of the Director Managers. What was exciting over the last 12 months and quite ironic is that our organisation had absolutely seen how effective we could be in bringing together our palliative care educators, our clinical leads and our ward champions to actually operationalise our response to voluntary assisted dying across our organisation, when our state legislated assisted dying to be part of our state's healthcare suite of tools. Ironically, we're a health service that's known for not supporting assisted dying, but we recognise the patient, for us to be working in this space in a system that is patient-centred, and it was very important for us. Now those enduring relationships have continued. The financial constraints of COVID has precipitated our health services restructuring, and we've been able to take these innovations even forward to look at a new innovative model for palliative care. It's been funded as what we were calling a palliative care evaluation unit in our acute hospital campus, and we're working toward establishing that relationship, that unit, not just as an inpatient service, but also having access to a hospital in the home type environment for those patients with the most complex palliative care issues who want to be at home. At Safer Care Victoria at this time, we were able to then we did find out that we were going to go through a similar restructuring, and we saw that we were able to streamline and cut back. The funding was being heralded to us, and that meant that actually our clinical network was under threat, and the lived experience was that we were going to lose our lead position, the position I was actually in. But actually we've been very lucky and important that I was able to find my voice like never before. I'm a bit croaky tonight due to the hour of the morning in Australia, but I was able to find my voice very clearly then, and we were absolutely able to use our influence in these spaces, not only to bring the lived experience to the table, but influence our other clinical leads and the other people in our table. We were able to influence and have representation, and I'm very pleased to say that we were able to find representation, and ongoing funding has been secured for the future. Still on this slide, I think what's important at the clinical coalface is that even though visits to homes were restricted and seeing patients were restricted, enhanced telehealth and online communications really allowed us great capability to be seen at more and more meetings and recognised by more people. From those virtual ward rounds to the cross-campus engagement, we became recognisable faces, even a little internal sort of celebrities with podcast activity, internal social media, and the occasional national newspaper and TV appearances with headlines such as "No person will die alone." We also had some fun activities. I think this is an important part of the pandemic, that we actually joined a lot of the sort of creative competitions around the hospital and photo collage competitions, and in fact 6 that were run across the 12 months of last year, with palliative care actually won 4 of them. And 2 of them are actually going to be archived, 2 into our hospital archives, but 1 into the state archives, for something that we were doing to sort of alleviate staff stress and continue staff well-being during the pandemic. So it's been a very exciting time for me. If I'm moving forward, it's really nice to ask these questions and reflect. Could my light have shone any brighter at this time? I think what's exciting to be able to report is that we're able to say that, yes, indeed, our light really did shine brightly. It's a lot to take in for me in 10 minutes to explain how we did this, but on reflection, seeking, connecting and influencing are 3 simple but powerful practices that I am proud that we've created the opportunities to grow and push the boundaries of where palliative care had a role in our healthcare service and within our Safer Care Victoria and our Department of Health. I could see this, but now others could see how we could contribute and sustain change and growth without really any extra funding. Interestingly, in January this year, I stepped away from my usual work as I was awarded a 6-month sabbatical break. I was working with a project engaging paramedics to be more connected to the palliative care system, particularly in the community. But what was really exciting for me is when I returned in July this year, I was able to see that other members of my clinical and academic teams were carrying forward much of this work that we had been planning in 2020. It really appeared to me that my approach in leadership had helped to enable and empower others to act, really to shine their own lights as well as mine shining for us all to celebrate our success. Thank you.